speaker for this session is Professor Andrew Bersten. Andrew is Director of Clinical Care, Clinical Services and the Head of the Department of Critical Care Medicine at Flinders University. He has an active research interest in lung physiology, a mechanism of lung injury, and ventilator assistance and heart failure. Most of you would know that he is the co-editor of O's Intensive Care Manual, and he's going to talk on non-invasive ventilation. Please welcome Dr. Andrew Bersten.
Thank you very much. I guess it's a bit of a change of pace, so there won't be much physiology, but maybe some discussion of clinical concepts in this talk. The little cartoon in the middle, I think, came, if I remember correctly, from the BMJ talking over a decade ago, talking about evidence-based medicine, and it was really trying to say that some things are fairly straightforward because we have the evidence for them, other things we know less about, and we need to be careful. And I think that that absolutely applies to the use of non-invasive ventilation, and I guess if I have to report any conflicts of interest, it would be that it irritates the heck out of me when I see somebody in the intensive care unit who's been consented for non-invasive ventilation, but not for invasive ventilation by people who know absolutely nothing about the issues. And I presume that's only isolated to my hospital, but if it's not, then maybe we all have some conflicts. So a quick summary, synopsis of what I'm going to talk about. I'm going to suggest that there's an increasing use of non-invasive ventilation over the last 2 or 3 decades, but the strong indications remain an acute exacerbation of COPD and pulmonary edema, and the rest of the indications are much more marginal. That if there is non-invasive ventilation failure, it's associated with an increase in mortality, and the hazard ratios for that are around 2 to 4. So that's a very significant consideration when you use this therapy. We'll look at the predictors of non-invasive ventilation failure so that we can think about when we might intervene and when not to intervene, and maybe look at some of the mechanisms of harm that occur, including decision making, the diagnosis, intubation, and the possibility of self-inflicted lung injury. So the paradigm that I think most of us have in our mind, and it's, might have some variations on this necessarily, is that if we can avoid intubation, then we might avoid the complications of intubation. So they might be the complications related to endotracheal tube, including airway function, ventilator-associated pneumonia. We might avoid sedation and paralysis, and that hopefully respiratory failure improves and patients discharged home. The flip side, I guess, is that intubation and ventilation gives airway access. That allows us to estimate respiratory system mechanics, and I think that's extremely important in the way that I function in the intensive care unit, and would be maybe another talk that I think would be worthwhile considering. Certainly I think the mechanical ventilator has more of a role than being an artificial respiratory muscle pump. I think it's actually an investigative tool for us to try to understand what's happening to the patient, what's happening in the course of their injury. It allows us to control lung stretch, and it facilitates some of the diagnostic procedures such as bronchoscopy and CT. Not that those are impossible with non-invasive ventilation, but unless you are very aggressive with bronchoscopy and CT with non-invasive ventilation, and I guess I've been doing bronchoscopy and non-invasive ventilation for 2 decades, but I think that's uncommon, then I think that you get a delay in those diagnostic procedures. So there's a fair bit of evidence that the use of non-invasive ventilation is increasing, and I'll present a few different studies from a couple of different sites. So this one from Alexandre de Moule, looking at a French survey that was repeated between 1997 and 2002, that showed an absolute increase in the use of non-invasive ventilation, up to around 23%. And I think if you looked at people who were not intubated prior to ICU admission, then up to half of the patients in these French ICUs were receiving non-invasive ventilation. Doesn't mean that they all continued to receive non-invasive ventilation, but that was how they started. I don't think it would be as great in Australia, but that seemed profound. The main indications were acute on chronic respiratory failure, and what the French would call de novo respiratory failure, and then pulmonary edema, cardiogenic pulmonary edema. So the de novo respiratory failure is really the group that we're going to spend a bit of time talking about today, because in acute on chronic respiratory failure, that's primarily acute exacerbation of COPD. When we look at that data, there's a couple of interesting things there. As I say, there's the acute, which would be ARDS, pneumonia, aspiration, atelectasis, and if we looked at the odds ratio using non-invasive ventilation, there was no evidence of improved survival. But if we looked in the chronic group, the exacerbation of COPD and pulmonary edema, then there was a significant odds ratio for an improvement of survival. Now, when we use that split to look at these patients, and so if you look at the graph here, and you can see, oops, I'm sorry, error. There's the acute and chronic. So the acutes are in the dark squares here, and so here's the evidence: non-invasive ventilation failure in acutes is associated with increased risk of death. Success for both groups improved, reduced risk of death. And if we look at the immunosuppressed group, which is particularly one that there's a lot of discussion about, and we'll come to that later on in the talk, if you've got an acute cause of respiratory failure and you fail, you have an increased risk of death. So that's what happens in France, and I think it's probably what happens everywhere in the world. So here's some more recent data from an experienced Parisian ICU that was reported a couple of years ago, 796 patients receiving mechanical ventilation, 465, 58% receiving non-invasive ventilation, so not very significant high use of non-invasive ventilation. If you had de novo acute respiratory failure, then you had an intubation rate of 50%. So half the patients failed. So if there's an increased risk of death if you fail, and half of them are failing, then you've got to wonder whether that's actually a really good thing to be doing. Similar data were there were not much difference really in the data between the immunocompromised and the immunocompetent data. In the US, there's evidence of increased use of non-invasive ventilation. So these are some data going through 2001 to 2009. I'll present some more data as we go on, but I think that you can see that there's increased use of non-invasive ventilation, which over this period increased from around 4% to 10% at that time. And the indications were widespread, but there was certainly an increased use in this de novo acute respiratory failure group. If we look at other data, again published more recently, this is from a cohort of 11.5 million cases, so I guess we'd say is that a mega study maybe? But anyway, it's a big data pool. If the patients did not have COPD versus those who had COPD, and you failed non-invasive ventilation, there was an increased risk of death. And there was both to fail and an increased risk of hospital death. So increasing usage, but poor outcomes in those groups. So I'd say that the use of non-invasive ventilation in respiratory failure is increasing in use, but I'm not sure whether we're using it appropriately. Now I'll go back. We first started, in fact, I was quite touched about 2 weeks ago. I had a phone call from the father of a young man, and I spoke to this young man. He was celebrating his 40th birthday. He reminded me that I'd looked after him since he was 9 years old. And he has spinal muscular atrophy and is doing extremely well at the moment. He's going to outlive his parents. That will create another problem. But if I'm not mistaken, we had the first non-invasive, first bi-level machines in Australia were imported to Flinders Medical Centre. So we had quite a significant history of that. And in the mid-1990s, Fiona Kameen, who's a respiratory physician in Queensland, was a medical student. She'd been a nurse at Flinders and then did medicine there. She's a medical student and did a physician training there as well. She took out these data from around 200 odd patients that we had looked after, and we classified them at that time as having pulmonary edema, COPD or lung injury. And the data's not particularly strong, but what we had done is look at their Apache 2 score, calculated a risk of death from that, and we all know that the Apache 2 score tends to overestimate the risk of death. But what was very interesting was that with the pulmonary edema patients, their actual death, their actual standardised mortality ratio was about half predicted. In COPD patients, it was around half predicted, but in the acute lung injury patients, it was 1.7. And we learnt then to be very, very careful, but we're still not that careful. If you look at the European Respiratory Society and American Thoracic Society Clinical Practice Guidelines that were published in 2017, the only strong recommendations for use of non-invasive ventilation remain in acute exacerbation of COPD and cardiogenic pulmonary edema. The rest of the indications are either no recommendation made or very conditional. So let's explore that a little bit. This is one of the early papers looking at the use of non-invasive ventilation in patients with severe community-acquired pneumonia. And if you have a look in the pooled data up here, whoops, I'm sorry, I've done that again. You'll see that the patients receiving non-invasive ventilation were less likely to require intubation. It looks like a good outcome. But if we take out the patients who had those with COPD and those without COPD, actually the data's gone. So it's the patients with COPD who are contaminating this data set. So those without COPD, there was no improvement. If we have a look at some data, this is, I think, three studies looking at the use of non-invasive ventilation in H1N1 influenza, you can see that the intubation rates were extremely high, up around 60 to 80%. Let's look at the immunocompromised data, and certainly in the last 15, 20 years, I guess these data have really dominated us. There are two studies that were published around the same time in JAMA and in the New England, suggesting that non-invasive ventilation reduced the need for intubation and might have been associated with improved outcomes in hospital in patients with immunocompromise. On the right-hand side of the study is a summary of some more recent data suggesting that there's no evidence for improvement when we start to put some of the more recent studies together. If we look at, this is a group of patients with hematology patients, you'll see that there was significant trouble in the non-invasive ventilation group, and if they failed non-invasive ventilation and then required an electrotracheal tube, there was an 80% mortality rate. Now, of course, it's an observational study, so we don't know whether those patients were sicker or they weren't sicker from those data, and probably they were sicker, but certainly there was no strong signal for an improved outcome. If we start to look at ICU survivors and ICU non-survivors in this data, again, non-survivors tended to have non-invasive ventilation failure despite marginal differences in their other severity of illness. So I think if we put a summary together and we're looking in this cancer group or this immunocompromised group of patients, there might be early benefit with non-invasive ventilation, particularly if there's not much respiratory distress, there's no multi-organ failure, and you use a hypervigilant approach. So if I'm looking after these patients, I will bronchoscope them, usually with non-invasive ventilation. It makes the procedure quite easy, the airway's held open, they tolerate it generally very well, and I don't want to get a delay in diagnosis. If they're failing, you need to be able to intubate the patient. If there's respiratory distress or they're sick, the advantage of endotracheal intubation is that you can avoid the respiratory distress. We'll talk about that. And you might avoid some of the non-invasive ventilation problems such as delayed intubation and maybe worse lung injury itself. So in this sort of de novo acute respiratory group, I guess we're thinking about ARDS, and many of you will be familiar with this study that was published in JAMA, I think a couple of years ago, using a helmet for ARDS, suggesting in a small single centre study that there might be better outcomes than face mask non-invasive ventilation with the helmet, possibly because of a higher level of PEEP in that helmet group. I think that's very interesting, something that we need to watch carefully. It's a small single centre study, and as more information comes, we'll see. I would just caution you that there's quite good physiologic data to say that there's more patient ventilator asynchrony with the use of helmet and that data's been around for around 15 to 20 years. I don't think that was, well, I know it wasn't examined in this study. It was using a very similar system to this. So I think we need some more data before we get any certainty about this result. If we go to the LungSafe study, and this, I guess, obviously much larger numbers, and they're looking at patients with non-invasive ventilation with ARDS versus those who were invasively ventilated. Overall, there was no difference in outcome, but in the patients with a PF ratio less than 150, and that's the centre panel here, done it again, centre panel here, the use of non-invasive ventilation was associated with worse outcomes. So I think, I'd conclude from that the strong indications remain, acute exacerbation of COPD and pulmonary edema. We need to be a little bit careful if we're moving around on the margins of that. So if we're going to use non-invasive ventilation on those margins, and I think many intensive care units do, and I think it occurs in our intensive care unit as well, we need to be very careful and understand what's going on and what the predictors might look like. So here's a little bit of data I'll present to you addressing that. So this is a relatively recent observational study in community-acquired pneumonia, 230 patients, 117 receiving non-invasive ventilation, non-invasive ventilation failure in 90 of those, so a very significant number failed. And the mortality around 2 to 3 times those who did not. Again, you might have, because it's just an observational study, there might have been sicker patients who failed. But if you failed, there was an increased risk of death of around 2-fold. The sorts of things associated with failure were the use of vasopressors. So if you're hemodynamically unstable and using non-invasive ventilation for community-acquired pneumonia, beware. Worse oxygenation at 2 hours and worse pH at 2 hours. A very old study published in JAMA, Laurent Brochard was the senior author on this, and I know that they were a bit taken aback at this. Now, about 70% of the patients in this, maybe more, were pulmonary edema patients, but a small number were pulmonary edema, majority were lung injury patients. Comparing CPAP with usual medical care, and there was no difference in the intubation rate. But what really struck these investigators was that there was an increased risk, or the increased incidence of adverse events when people were having CPAP in that particular group, 23% versus 8%. And the sorts of things that they described were cardiac arrest, stress ulcer. I mean, cardiac arrest in an intensive care unit should be, I think, extremely rare. And if it's not rare and if it's unexpected, then we ought to search damn hard for what we've done wrong prior to that cardiac arrest moment. So they were really suggesting that there was something wrong with this therapy that was manifesting itself with adverse events. Sometimes people delay intubation because they're so keen to show what they're doing is the right thing. So again, quite an old study, group of very enthusiastic emergency department physicians. Maren Koloff, I think many people will know, has been involved in a lot of antimicrobial therapy studies, particularly community-acquired pneumonia more recently. So looking in a group of patients receiving non-invasive ventilation versus those who didn't receive it, the same number were intubated, but there was incredible delay, around 26 hours compared to 5 hours in the group receiving non-invasive ventilation, and there was a tendency towards increased mortality associated with that delay. If we just look at the Esteban data here, which is using post-extubation non-invasive ventilation, you can see that in a group of patients with respiratory distress within 48 hours, the reintubation rate was exactly the same, but the hospital mortality was increased in the non-invasive ventilation group, and the time to reintubation was significantly increased, not dissimilar to the previous study, this time 12 hours versus 2.5 hours. So delay in reintubation because these non-invasive ventilation was associated, not causal, we don't know that, but it was associated with an increase in hospital mortality. So I think I'd suggest that there's evidence that if you fail non-invasive ventilation, it's associated with an increase in mortality, and we should start wondering what the predictors of that might look like. In general, these are quite good predictors, and we will just focus on hypoxemic respiratory failure rather than the hypercapnic group, so that if you don't improve oxygenation in the first couple of hours, more likely to fail. If you're older, you're more likely to fail. If you've got a higher acuity, if you're sicker, you're more likely to fail. SAPS-2 of 34 is not that high. A SAPS-2 that is not a sick ICU patient. If you have ARDS, you're more likely to fail with community-acquired pneumonia and multi-organ failure. I was particularly taken with this relatively recent study, again, it's an observational study from 54 French and Belgian ICUs over a 2-month enrolment period, 568 patients with non-invasive ventilation. Again, the same sort of classification, acute on chronic 250, pulmonary edema 58, de novo 116. Similar sort of data for non-invasive ventilation failure and for hospital mortality, so that if you had de novo, it was more likely to be associated with non-invasive ventilation failure. If your SAPS-2 score was high, so if your physiologic disturbance was high, more likely to be associated with non-invasive ventilation failure. But this one I thought was quite interesting, which was that if you had moderate to severe dyspnea, so that's a Borg scale, I think, was 5 and above. So it's not a great deal of dyspnea, but if the patient was still somewhat dyspneic, after their first session, whatever that means, but usually a first session would be after 8 to 16 hours, then you had a significant increase in risk of non-invasive ventilation failure and a significant increase in risk of mortality. So I think we can say that the predictors of non-invasive ventilation failure are a failure of early response. So if you're going to do it, be careful, look at the response. If things are not better quickly, then you've got evidence that it's not time to persist with this therapy, in my mind. And if the patient is unwell for other reasons, so if you're dialyzing them or you've got them on vasopressors, you're starting to look at a very risky group of patients here. Okay, so why would this occur? What are some of the reasons? And I think this is all postulate rather than more than that, but I think they make sense to me, and I just want to explore them very briefly with you. And I talked about some of these 2 days ago when I was talking about some of the pros and cons, and this was really some of the problems with spontaneous ventilation, what happens. But if you don't relieve dyspnea adequately, then you get unrelieved drive. And high respiratory drive has a couple of things. To certainly get high transdiaphragmatic pressures, and therefore high local pressures and local stress and strain on the lung that could cause lung injury and cause hydrostatic pulmonary edema. We all know, and we all ignore it, because we can't do much about it, that when you have a high respiratory drive, you tend to have high uncontrolled tidal volumes. And it's very difficult to control tidal volume under those circumstances, so you now have high diaphragmatic pressure leading to high regional stress and strain, and high drive leading to high global stress and strain through lung stretch. You might have inadequate support for the patient, and so you're holding on because it's convenient. We've all done that. Sometimes patients are not able to tolerate non-invasive ventilation for long periods of time, and possibly that is why, one of the reasons, plus the use of higher PEEP, why the helmet was effective, but I'm just suggesting we might have some caution there because it's a single centre study and there is the caveat of asynchrony that may occur with the use of the helmet. When we lose, as I've talked about tidal volume there, that might be exacerbated by pressure support ventilation. I think you can keep turning the pressure support ventilation down, but if you're measuring tidal volume, you still find that's hard to control tidal volume, and you might have this self-inflicted lung injury if that is a real thing. I think it probably is. I've talked about delayed intubation and the risks of delayed decision-making and diagnosis, and if you are hyperacute and you do bronchoscopy and investigations and all the things that you would normally do in an intubated patient, you might get around that, but I think many of us do not do that in reality, even if we talk about it. When you have somebody on non-invasive ventilation and you finally have to intubate them, it may be because the disease has progressed, and I'm always worried about it when I'm taking somebody failing non-invasive ventilation and intubating them there, because you're taking more. It's harder to pre-oxygenate the patient adequately, no matter what you do at that time. They're more likely to desaturate, and if there's any difficulties with intubation, it will be more dangerous. Now, there's some quite good evidence, particularly in the anaesthetic literature, about apneic oxygenation, but I think the evidence in lung injury is that it's not particularly effective. And that's not surprising, because you really have a fixed shunt there and it's not effective in those patients. These are some data, I think, from one of the Parisian intensive care units. Might be Laurent Brochard with the senior author on this paper, if I'm not mistaken, looking at high tidal volume and its association with non-invasive ventilation failure and acute hypoxemic respiratory failure. Now, this is an experienced ICU. They've been doing non-invasive ventilation for over 20 years. Their protocol targets a tidal volume of 6 to 8 mils per kilo, and I think if you have a look at the dashed lines there at 6 to 8 mils per kilo, you would recognise that only around 10% of the patient had controlled lung stretch, despite the fact that in an experienced ICU, that's what they're trying to do. If we look at the ARDS group of patients there, those with higher tidal volumes, and they were around 10 to 11 mils per kilo, had worse outcomes than those, well, they were more likely to fail than those who didn't. Now, look, that might just be high respiratory drive, worse disease, worse outcomes. It might be that high tidal volumes, more lung injury, more ventilator-induced lung injury, because there's more stretch associated with that. But that, you can't control lung stretch. So I guess just in summary, I think that the decision-making is likely to be delayed. That might be one of the mechanisms. You might fail to make your diagnosis at that time. You might get more lung injury because you can't control tidal volume, you can't control regional stresses in these patients. So coming back to this slide at the very beginning, I think that there are some patients in whom we have relatively strong indications for non-invasive ventilation. Some of them still fail, and we still need to know when to intervene, and if we're going to intervene, then I think we should intervene as early as possible. But there's lots of other circumstances where clearly, globally, and I've shown you some data from Europe and the United States, I suspect it's exactly the same in Australia and New Zealand, where we have not so strong indications, and we ought to tread carefully with those patients. Thank you.
Thank you very much, Andrew. We probably have time for one quick question, if there's any from the audience and you wanted to go to a microphone. Just one up here.
Rajiv, there's a microphone there.
Rajiv Hegde from Royal Brisbane Hospital. One of the things that has happened is advent of high-flow nasal bronchs. And I just wonder, except in patients with COPD and acute pulmonary edema where there is clear indication for NIV, if you are failing high-flow nasal bronchs, or should we just using high-flow nasal bronchs and then go to intubation rather than using NIV?
Okay, so I think you're right. I think if you fail, so Shailesh gave a very nice talk on high-flow nasal oxygen 2 days ago. He might be a better person to speak directly with about that. But one of the points he made there was that generally with high-flow nasal oxygen, you decrease respiratory rate. But carbon PCO2 is unchanged. Now, there might be lots of mechanisms going on there, but it might suggest actually that tidal volume's gone up as well. So that the data in this sort of group of patients, high flow nasal and non-invasive, look like they're very similar interventions. I think if you're failing high flow nasal, you've failed that intervention, it's time to move on. It's not time to delay. I sort of agree with you.
Thank you.
All right. Thanks very much, Andrew. It's a great pleasure to welcome our final speaker in this